Dr. Vinita Gupta with us, who is going to talk about non-IOP dependent risk factors in glaucoma.
Good morning, everyone. So I'll be talking about, as Dr. Sushma has already introduced my topics. It's about the non-IOP dependent risk factors in glaucoma. We all know that glaucoma definition is now not based on IOP, and it does not merely define the presence of elevated IOP as it has evolved over the years. So the emerging question which has come up in the glaucoma management is the patient whom we thought was well controlled with a well controlled IOP, is he actually well controlled? Patients have shown to progress despite IOP control. We have the ocular hypertension treatment studies showing that 5% subjects do progress despite a 20% IOP reduction. The CNTGS has shown that 12% of patients enrolled in the study, despite a 30% reduction, still progressed. And similarly, the early manifest glaucoma trial again showed that 25% IOP reduction also did not leave 45% of patients which still progressed. So elevated IOP does increase the chance of developing glaucoma and glaucoma progression, but there are various other risk factors which need to be considered. Some of them which we have classified as mechanical factors and vascular factors. Mechanical factors, some of which are not modifiable, like your age, the sex, the race, the family history, the genetics, and whether you have a refractive error or not. But the other anatomical factors, which is the thinning of your lamina cribrosa, your other variations in it, that's your central corneal thickness. And then we have various vascular factors which are related to your blood pressures, your ocular perfusion pressure, which is indirectly linked to your blood pressure, and lots of various vascular diseases which cause a lot of autonomic dysregulation, and other vascular conditions like migraine and Raynaud's phenomenons, which affect the exoplasmic flow as well as ocular blood flow, and the disc hemorrhages, which is a classical feature of when seen in non-metastatic glaucoma and is a sign of progression. So there's a very complex relationship between, but the basic things which are being affected is your ocular blood flow by all these factors. So besides the IOP, so let's look at these factors one by one. Let's talk first about the epidemiological risk factors, which I've listed in this flow. And for age, it has been seen that the prevalence of POG increases from 0.6% in a 40-year-old person to almost 7.3% by the age when you become 80. So there's almost a 12-fold increase in your lifespan of 40 years. Similarly, there's an increasing, we all know because of changes in anatomy of the eye, there's an increase in the PSEG as well as in age. And this is not only the prevalence increases, but also you're likely to have more progression than younger patients at the same level of IOP. Then we have the race. Obviously, the higher prevalence of POG is seen in African and Hispanic population. Not only they have a higher incidence or a higher prevalence, but they have a earlier presentation and more faster progression. Similarly, PSEG, as we all know, is more common in Asians as compared to the other areas. Then we have the family history, the inheritance. We have, glaucoma is now being classified as a polygenic inheritance, and almost 70% estimated heredity is there in those cases, for both for PSEG as well as for POAG, and various genomes wide studies are going on, which have identified different types of genes for this. Then we have your gender. PSEG is more common in females, again because of the anatomical constitution is like that, and BMI, low BMI is associated with NTG again, and the socioeconomic status. There is a greater severity of glaucoma is if you have a lower socioeconomic status, which is basically related to certain other nutrition and other factors which are coming into play now. The next group of risk factors which I'll be talking about, the ocular risk factors, which we all know, the corneal thickness, the hysteresis, and your disc hemorrhages and the refractive error. We already have some knowledge about them. So the corneal thickness, we all know that the thinner corneas are at a greater risk of developing glaucoma and also at a greater risk of glaucoma progression. And they also show an increased severity of visual field loss. So that is a faster progression. Similar is the case with the lower corneal hysteresis, which is associated with the faster glaucoma progression. Then we have a optic nerve head. The large cup disc ratio is an important predictor for the development as well as for the progression of glaucoma. And acquired optic nerve pits, which is seen again more commonly in NTGs, is a rare risk factor, but it is a risk factor for glaucoma. Disc hemorrhages, as I already mentioned before, 5 to 25% of patients of NTG have disc hemorrhages, and again that's a sign of progression. And they are almost 6 times more likely to develop glaucoma than eyes without a disc hemorrhage. Then we have the refractive error. Hypermetropic eyes are smaller eyes, so they're more prone to develop angle closure. as compared to myopia, which is associated with the increased risk of POAGs. And in myopia, it is not just the refractive error, it is also the reduced RNFL thickness and the peripheral blood flow, which is affected in these cases, which leads to a faster progression. So not only the prevalence is high, but there's also a faster progression. Now let's look at the systemic risk factors. So with systemic risk factors, we have the various neurodegenerative diseases. There are studies which say that there's increased prevalence in patients with Alzheimer's, and although the other risk of CNS degeneration is CNS disease is that increased risk of stroke has been seen in patients with glaucoma, again indicating that glaucoma has a vascular basis to it. Migraine also has been seen, patients with migraine have been seen to associated with increased risk of increased incidence of NTG as well as primary open glaucomas, and almost 25% higher risk was found in these patients. Then we have the personality. People with type A personality, anxiety and depression may not actually develop more glaucoma, but obviously glaucoma patients tend to develop this because of the disease being a chronic disease, a disease which is not a totally controllable disease. So obviously these traits become more manifest in these patients who are already suffering from glaucoma. And there are certain drugs we all know which can induce acute angle closure glaucoma in eyes which have a predispository, like tricyclic antidepressants and other antipsychotics. Then we have the primary vascular dysregulation, which is a Flammer's syndrome, which has an increased incidence of NTG associated with it, while the secondary vascular dysregulation, which we see in various autoimmune conditions like giant cell arteritis, rheumatoid, lupus, ulcerative colitis, Crohn's disease. All these patients again are known to have secondary glaucomas, not the primary glaucomas per se, but known increased incidence of secondary glaucomas in these cases. These secondary vasospastic phenomena like Raynaud's, which are seen in homocystinuemias, as well as because of your antiphospholipid antibody syndromes, can also increase your prevalence of NTGs. Systemic hypertension, again 47% of glaucoma patients do suffer from systemic hypertension, and that's why nowadays doing blood pressure monitoring, especially when we are doing diurnal variations of IOP, is very important, because that helps us in knowing the ocular perfusion pressure also of the patient. Hypotension again is very bad for glaucoma, as I said, because we now identify that glaucoma is a vascular condition. So it has been seen that the risk of OAG in subjects with diastolic blood pressure of less than 50 mmHg is 4 times more than that if the ocular perfusion pressure is better than 80. And ischemic heart disease, again there is an increased incidence. It is the other way around. The patients with glaucoma tend to have an increased incidence of ischemic heart diseases. Dyslipidemia, again it is an function of autonomic dysfunction happening there. So again, having this causes affects the optic head perfusion, and therefore worsens the glaucoma in patients who already have these problems. Then we have the chronic obstructive pulmonary disease. No association has been found as such between the chronic obstructive pulmonary disease, except for the drugs which we already know, like beta blockers. If they're not non-selective beta blockers are used, they can worsen the symptoms. While it has been seen that OSA patients of glaucoma may suffer from OSA. So that is one thing which we have to take care of. And the therapies which are given for this OSA, CPAP, may worsen glaucoma. Diabetes, we all know, there is almost 30% increased risk of POG in patients with diabetes. And same in thyroid disease, again, it has been seen that because of the orbital congestion which is happening there, it can lead to elevated IOP in those cases. For pituitary adrenal disease, again, we already know the reason for that. That is the cortisol is sharing, and obviously your IOP gets affected because of that. And same way, acromegaly has been seen to have a high risk of OAGs. Then we have lifestyle conditions, which is smoking. Smoking obviously will worsen your vascular blood flow to the optic nerve head. So there's a direct association. Blue Mountains eye study also found a direct link with the caffeine. More than 200 milligrams of caffeine per day was found to again raise the IOPs. And a lateral decupitative position, especially sleeping on one side regularly, affects your IOP in that eye. Again, that has been found in the studies. Then we have occupations such as trumpet blowers, glass blowers, etc. They increase your intrathoracic pressure, again changing your intraocular pressure. Again, various yoga postures which have been implicated to increase the IOPs. Excessive smartphone use has also been said in certain cause IOP fluctuations and the sleep-wake disturbances with prolonged sleep latency, which may be affected because of this excessive smartphone use. Nowadays, even studies have gone which have talked about the CSF variations and transluminal pressure variations, which have also been now being wider variations are said to be associated with the higher in the NDG patients. One good thing about this, while we are studying all these novel risk factors, is the estrogens have a protective role. So that is which has come and may have a future prophylaxis, especially in females after the menopause, giving them estrogen replacement therapies, especially if the patient has a OAG or has a tendency for developing open-angle glaucoma. Probably estrogens may have a beneficial effect in them. So just last 1 or 2 slides for ocular blood flow. So as I've been talking about, this is all basically, most of the factors are vascular. So we have a lot more role of ocular blood flow nowadays. And it has been identified as an independent risk factor for glaucoma progression. So lowering of the blood flow to the optic nerve is correlated with not only increased prevalence, but also the worsening of your glaucoma. And various studies are there which show that, which are from various wide populations all across the world, and they have shown that reduced ocular perfusion is a very, very important risk factor. Obviously, various vascular systemic diseases are affecting the ocular perfusion pressure, so we have to control and manage those systemic diseases also. And it is important that unlike other risk factors, which age, CCT, which we have been talking about a lot, this is something which we can actually modify. So we have to take ocular blood flow seriously. So just to conclude, I will say vascular risk factors are very important risk factors nowadays in the pathogenesis of open-angle glaucoma and its related diseases. Most of the patients our glaucoma patients are elderly, and they have usually all these systemic comorbidities as vascular diseases. So therapeutic strategies should not only target IOP, they should target ocular blood flow as well. And there's enough motivation to move towards these agents which can target these. And further research is also happening regarding various complementary therapies, like especially Dr. Tanuj has done a lot of work on yoga and other things, and meditation as such, in affecting your lifestyle and indirectly increasing your blood flow and all those other factors. So it ultimately affects your blood flow, ocular blood flow. So treatments, we are actually looking for treatments which can actually reduce your, prevent your thinning of your RNFL and RG cell loss. Thank you.
Well, thanks, Dr. Vinita, for bringing out such an exhaustive list of factors which are other than intraocular pressure. And it's really, really useful information, and that makes us understand that NTG is actually maybe a ocular manifestation of a systemic disease. So we have to be really careful in evaluating a patient, and the amount of history taking we have to do is enormous. One more factor to add to it, I would say, is the immune factors have also started showing its role.
Autoimmune diseases are linked.
So it's really exhaustive. I just wanted to ask you a question. In a clinical situation, when you come across an NTG patient, do you try to calculate ocular blood flow? I mean, how do you go about if your patient of NTG is there?
First thing, as I said, NTG, as you said, no, could be a manifestation of systemic disease. The first thing is I do massive investigations. For me, a complete cardiological as well as complete neurological examination is a must for every patient that I'm clinically suspecting that patient to be an NTG. And as I said, I always do my diurnals with my blood pressure monitoring. So I do calculate ocular perfusion pressure for all those patients. I do that.
So it's very, very important to check the BP. Anyway, when you're doing a diurnal variation, it hardly takes anything to just check the blood pressure of the patient. And a lot of situations you will figure out that, almost, I would say, 1 out of 10 patients will definitely come out to be having nocturnal hypotension, and you can really take care of it. The other investigations, of course, cardiac is something that is very, very important and has to be done. But other investigations can be related to the history that you take. That if a patient has a sleep apnea, you can go to sleep studies.
Yes.
If you history of joint pains and all, you can go to immunological studies. Younger patients would require neurological investigations. So anyway, thank you for bringing out a very important aspect. Let's go to the...
I have a question. Do you think ocular blood flow has any role in early diagnosis of glaucoma? Early glaucoma.
Early diagnosis, if there is, as I said, if I am suspecting any patient, let's go to a patient of suspect who comes
glaucoma
to me.
suspected.
So if it's an open angle, I always prefer to do, even the fields, maybe the fields are coming normal, the OCT RNF is normal, still I would like to do his diurnal. Because I do not know, because he's come to me one time in the clinics, I'm recording his IOP only once. So I do a diurnal, and the diurnal always, it has become my habit. I'm doing blood pressures. I myself, I have narrow angles myself. I got my own diurnal done, and for the first time when I got my diurnal done, my blood pressure dips to 80 by 40 actually at night, at 2 a.m., which I did not know myself.
Yeah.
Because I was never awake probably at that time, and even if I was awake, I was probably not symptomatic at 2 a.m. But when I recorded my BP during that diurnal, I realized I have such, and I calculated because my IOPs were also low, so my ocular perfusion pressure was not very low. Because my IOPs were also relatively low only. My maximum IOP was 12 throughout the day. But otherwise, if you have a higher IOP and a low thing, you will have a different ocular perfusion pressure calculation. So that will affect. So that's when say ocular perfusion pressure, if you know that, and if ocular perfusion is consistently below 40 or something like that, then definitely there is something vascular dysregulation happening at the level of the optic nerve. And if you have some other risk factors also going along with it, then obviously you may be at a high risk of developing glaucoma. Such patients probably need to be kept on a better or earlier follow-up. That is the only thing.
We
Thank
have one
you.
question before we go to the next.
Sorry? Thinner cornea per se is known to have there is an association which has been found. We already know that if you have a thinner cornea, you will be recording a false low IOP. That is different. But no. Otherwise also, thinner corneas have been seen by even the ocular hypertension treatment studies showed for the thicker corneas, it's an independent risk factor. Similarly, thinner corneas have an independent risk factor for the progression of glaucoma, which has been found in studies.
So to answer your question, it's a associated risk factor, not a causative risk factor.
Yeah.
Okay, so this association is clearly established, but that is not the causality is not established. Thanks, Dr. Vinita.